Hi everyone, welcome to your induction talk on infections and infectious diseases. My name is Dr. Sahota. I'm one of the consultants in infectious diseases based here at the Leicester Royal Infirmary. And this talk will be in two parts just to help you digest and break it down a little bit. For many of you, this may be the first specific talk you've had on infections since your year one module, which will probably feel a long time ago. You may well feel that there are things you've forgotten, gaps in your knowledge, and that's absolutely fine. We're not expecting by the end of this block for you to be experts in or know lists and lists of microbes and antimicrobials, but we do hope to give you a good grounding in how to recognize a patient with infection and how to think about investigating and managing them. For those of you based at UHL, you'll be seeing myself and my team during your week with us on IDU. For those of you based at the DGHs, you may well not have any specific infection specialists teaching you there, but I'm very sure that the consultants you'll be with will have a lot of knowledge in how to manage infections relevant to their specialties. And remember, infectious diseases, infections, is very much a generic subject which crosses all specialties. You can also come back to these lectures and these talks for reference and for revision, and the same material or much of the same material that the UHL students will be having access to, will have access also on Blackboard. So this is just to remind you of the ID block objectives which you'll see in your workbook. Now, there seems to be a lot, but the systematic approach is really the key thing. So how to think about the patient with infection, how to investigate, and how to manage, going through all the systems and the particular infections that you can see listed there. And I'll go through them as we go through this talk. I want you to be able to recognize the clinical presentations caused by commonly found microorganisms. Again, I'm not expecting you to know lists and lists, but you should have a good idea about the common viruses, bacteria, possibly fungi and parasites that you're likely to see in secondary care during this block. You should recognize the important causes of immunosuppression, including HIV and immunosuppressing drugs, which there are now a lot of in a lot of the specialties that you'll be going through. Although, of course, I'm not expecting you to be experts on any of those conditions or specifically those drugs. You should definitely have a good understanding of the principles of infection control, which includes antimicrobial stewardship. And I will be helping guide you through how to understand antibiotics in particular and when they are used. There's a few other objectives there, such as return traveler with fever. You'll get a specific lecture from me on this, a recorded one like this, which will be available on Blackboard for you to see in your own time. When you're working with me, you'll definitely go through pyrexia of unknown origin and get an idea about how to recognize and differentiate acute versus chronic infections. Particularly for this objectives, we'll recap some of the basics that you went through in year one. We're going to talk about microbes and what the interaction is between microbes and patient factors and how this then develops into disease. When you're working on the wards, you will have very frequent access and also communication with microbiology laboratories and ID. They will be giving you results, and you need to know what to do with those results. You need to know what they mean. If someone gives you a particular gram stain result or tells you that an organism is growing in a blood culture, and you need to be able to relate that back to the patient you're looking after, see if it makes sense in terms of what you're doing for that patient, and know what changes need to be made. And when we put all that together, you should have a good grounding in the common infections you'll see. And in particular, you'll be able to know and should know and be aware of how to recognize and manage sepsis, which is really quite key. So let's start with the case. So you're now the F1 working on the acute medical unit. You see an 82-year-old lady, Mrs. Peterson, who's been referred by her GP. She's presenting with the information you have, at least on the clerking sheet, with a swollen, painful lower leg for the last 3 days. And for the last 1 day, she's been feeling more unwell. She's got fevers and rigors, so she's been shaking with her fever. She's feeling breathless and also quite lethargic. When you go and see her, you find that in her past medical history, she's known to have type 2 diabetes and rheumatoid arthritis. And a couple of weeks ago, an important piece of information is that she had a total knee replacement done electively for osteoarthritis. She's on prednisolone and methotrexate, and she's got an allergy to penicillin, which causes her to have a rash. So as an infection specialist or as a general medic, the questions that come to my mind is, what else would you ask at this point if you were seeing her for the first time? And based on that, what would be your differential diagnosis here? What would you look for on examination to help you make your differential diagnosis? Which investigations would you request? Which microorganisms are likely, or there could be more than one, if this is an infection? And what treatment would you give? So these are all the questions that I want you to start thinking about, and hopefully this framework will give you an idea about how to answer them. So when we look at infection, there's two major factors that we need to take into consideration. Factors belonging to the pathogen itself and factors belonging to the patient. Now, as you know, we all have a microbiome, we have bacteria in and on us all the time, and that is not always causing us disease. Sometimes we live symbiotically with the pathogens within our microbiome. So what happens to cause disease? What factors change or are there that leads a patient to become unwell with their pathogen? Or what happens with the pathogen itself? What are the factors there that lead to disease and particularly to a state of being unwell? So what's the mechanism of infection? Ultimately, what will you then do about that in terms of your management, and what is the outcome? Ideally, the outcome would be to cure the infection, but as we know, some infections are incurable and become chronic, and unfortunately, some also lead to death. If anyone ever asks you to differentiate or give us a differential diagnosis on infection or infectious diseases, always go back to basic principles. So split your pathogens. I would list them as per virus, bacteria, fungi, and parasites. In secondary care, in the attachments you're on, you'll come across mostly viruses and bacteria, and we'll go through those in more detail, particularly with regards to sepsis. Fungi you may see in some specialties, and hopefully you'll be aware that most fungus, at least invasive fungal infections, are caused in the immunosuppressed. So this may be patients with HIV, for instance, or those who are on immunosuppressing drugs. Simple superficial skin infections are quite common. It can happen in conditions such as diabetes, and you can also get infections such as candida, either vaginally and occasionally in the mouth. And it's worth thinking about why that is. Parasitic infections, again, you'll see less commonly, but they're quite important to us in travel and the person with fever in the return traveller, which you'll come across in my lecture. So the main focus here is probably going to be viruses and bacteria in particular. So let's go through the factors that might lead to a disease state when it comes to infection. So let's talk person factors. Which factors are they particularly in the patient that might lead them to become infected? We'll break this down. So age is clearly going to be very relevant. Now, age, as we know, it's we've hopefully all seen now patients who are biologically 60 but physiologically 90 and vice versa. So although age shouldn't be a factor on its own, we know that immunity does wane with older age, and so certain infections are much more relevant in the older population, and they may lead to more severe infection. So we know that, for instance, with COVID-19 causing more severe disease in patients who are older than, let's say, 60. Gender, it is quite relevant. So certain infections will occur only in men and certain only in women. So in men, what do we have? We've got prostates that women don't, so we can get prostatitis. In women, you'll have infections related to breast, so mastitis, postpartum, pelvic inflammatory disease, obviously, and any of the infections related to labor, so retained products of conception, and also postoperative wound infections, let's say after a cesarean. The physiological state is obviously really important. So, as I said, we know that age and gender play a part in that. But also, if we think about the nutritional state of the patient, so for instance, patients who are homeless, who have chaotic lifestyles, may well be malnourished, and that will play a big part. Patients with high alcohol intake, that will also affect their immune system. And then comorbidities play a massive part. So if we think about common comorbidities, one being diabetes, we know that diabetes can lead to many infections, particularly those involving the foot, so diabetic foot infections related to neuropathy. The patient gets an injury which they're not aware of due to poor sensation. That can then lead into an ulcer, and if left uncontrolled, can actually go on to sepsis of the foot or even osteomyelitis. Other comorbidities also are going to be relevant, particularly with regards to medications. So as I said, as I mentioned already, many patients are on regular medication which does cause immunosuppression. So one of those is corticosteroids, which may be used in a vast variety of departments and specialties, from gastro to neurology to rheumatology. And now we are using more and more so the biological agents as well, again, in all of those specialties for a variety of conditions. And we know these suppress your immune system. So we must become more aware of patients who are on them and the risk of infection. Social factors will play a big part. I've already mentioned homelessness, but also things like intravenous drug use will lead to certain infections more so. Time, now this is quite important. So we're here talking about calendar time, so the length of symptoms. So for instance, this is really relevant in the return traveler, so that we often count the point when they return from their travel to the point that they get their symptoms as a key point in helping to decide their incubation period, particularly which then gives us an idea about differential diagnoses. And also, the other thing about calendar time is we know that certain infections occur more in certain seasons. So in the winter, we'll be much more aware of infections like norovirus, winter vomiting virus, and also obviously things like influenza. And finally, place and environment. So one aspect is, where do they live at the moment? Are they in an environment which might lead them to have infections more frequently? So a nursing home environment where things can spread, infections can spread between residents much more easily. But also, have they recently traveled abroad? Have they been in a hospital environment which might make them more at risk of multi-drug infections? So all these things are going to be relevant. Now, mechanism of infection is really quite key. This is really key for you to get your head around, to understand how an infection or how a pathogen gets into a place in the body where it's not supposed to be. Now, that might be an external pathogen that shouldn't be there at all, or it may be something that's normally as part of your microbiome, sitting on your skin, for instance, that is normally sitting there happily, not causing disease, but when it gets into the wrong space, it does cause disease. So let's think about contiguous infection or direct spread. This is probably the simplest sort of picture you can form in your mind. So let's take that picture of a skin infection. So cellulitis, for instance. So we know that we've got a number of organisms sitting on our skin, predominantly staphylococci and some streptococci. So you'll have heard of Staph aureus and coagulase negative staphylococci, for instance, which we'll talk about in more detail. If there's a break in the skin barrier, those bacteria manage to make their way into deeper tissues. That is contiguous spread. So if it gets into the dermis, it will cause cellulitis. If it spreads further down, think about the layers beyond that, it may well spread into the fascia, into the muscles, and even into the bone. And the same thing can happen, for instance, in the inner ear. If the infection, inner ear infection particularly becomes very severe, it can actually invade into the meninges and cause meningitis or even brain infection. Hematogenous spread. So again, if we take either of those scenarios, you've got your contiguous spread from external to internal. If that then ends up in the bloodstream, you'll get hematogenous spread. So the bacteria will float away into the bloodstream. This may well lead to septicemia or sepsis and may actually start seeding in other parts of your body. So Staph aureus in particular does this quite frequently and likes to stick to many parts of the body, particularly prosthetic material. The other sort of classical hematogenous infection is infective endocarditis, where you've got bacteremia, which manages to get into the bugs manage to get into the bloodstream from the mouth, and you then get the bacteria sitting on vegetations, on valves which are already formed. So this is all hematogenous spread. Inoculation. So classically, I would say intravenous drug use. So many intravenous drug users well, eventually, as their veins run out, they may well start going blind into the skin or into the muscle. Many will use non-sterile needles. So you can just imagine infections, environmental pathogens sitting on those needles which manage to get into the bloodstream, or your pathogens like Staph aureus sitting in the skin which manage to make their way into deeper tissue. This can then form clots in deep veins, perhaps in the femoral vein, and also lead to hematogenous spread. And on top of that, there's also the risk of blood-borne viruses such as HIV and hepatitis C. Ingestion, so your classic sort of food poisoning here we're talking about, so fecal oral spread perhaps of organisms, poor hand hygiene, poor hand washing, you ingest either a virus or a bacteria, which usually leads to either nausea, vomiting, diarrhea, or possibly both. Very easy to spread. Inhalation, this is the other one that's very, very easy to spread between people. So when we worry about easy spread, such as COVID-19, we mostly worry about respiratory infections and infections spread by the fecal oral route or the oral route in particular. So common cold, influenza viruses, many bacterial infections that cause lower respiratory tract infection, including TB. And the infectivity very much depends on whether they are spread by aerosol or droplet, with aerosol spread being much more likely to happen with much fewer particles of pathogen. Vectors are really important, particularly in travel infections. So we know that many vectors carry infections. So the mosquito for malaria and dengue, for instance, and the ticks when it comes to Lyme disease. So this will be relevant, particularly in your infection from return traveler talk. Vertical transmission, again, important. Thankfully, we've got a lot of processes in place to protect or to prevent mother-to-child transmission of many infections now, particularly things like HIV, which would classically cause significant burden of disease in the developing world. But also there are other infections like syphilis and rubella, which if caught in pregnancy, or at least in first or second trimester, can cause a lot of problems. And finally, sexual transmission. So this is something we should always consider, whether it's to do with acute HIV or chronic, but also things like pelvic inflammatory disease. Now, infection management, this is really what I want you to focus on specifically. When you're seeing your patients on the ward, what are you going to be doing? History, as for anything, is going to be most important. So you'll get all of your information, or I'd say 80% of your information from the history. Is this an infection at all? What are the features of this history that tell me this is infection? Could there be a non-infective differential diagnosis? You can then focus your examination to look for the potential source of infection. Sometimes it'll be very clear if someone's sitting there coughing and spluttering away, they've got low SATs and high respiratory rate, it's most likely to be respiratory source. If they've got severe diarrhea and vomiting, fine, it's GI, you may well feel some abdominal tenderness. Cellulitis, you'll see that fairly obviously. But sometimes, and on our ward in particular, we get patients where they've had a fever for a few days, another specialty has given them antibiotics, have not gotten better, and they're sent to us as a pyrexia of unknown origin. And that's where we really have to go through each system in a focused way to see if they have any symptoms or signs that might lead us to tell us where the source of that infection is. And when you come to see me on my ward, we'll be definitely going through that in more detail. Finally, that will help you, I would hope, to make a diagnosis based on the investigations, and that should be bedside tests, blood tests, microbiological tests, including MCNS, microscopy, culture, and sensitivities, and also radiology. All of these should help you decide where the infection is and what the infection is. And then finally, that goes to management. Now, you may think, the first thing that comes to mind if I say, how would you manage this infection? It's probably going to be something like antibiotics. But we mustn't forget that infection treatment is definitely holistic. So you've got your specific treatment, which will include antimicrobials, but then always think about source control. So if you've got someone with an abscess, antibiotics will help to some degree. They may help reduce the burden of that pathogen and perhaps treat the initial sepsis. But unless you get into that abscess and clear it away, you are not going to relieve that person's infection completely. And in fact, it may well persist. So the person with abscess potentially needs an incision and drainage. It needs surgical intervention, whether it's abdominal or skin and soft tissue. Alongside specific therapy, you've got your supportive always. So symptom relief. Many infections cause pain, whether again it will be the leg, the lungs, and that can obviously affect patients' general well-being. And it's important to relieve pain, provide fluids in terms of sepsis, which I'll get onto later as well, and restore their physiology, whether that's supportive management on the ward or potentially needing intensive care. And the final part of management, which is again very important, is infection prevention. So you need to identify early on, is there a risk of this infection spreading to other patients around that patient on the ward? And is there also a risk to the staff members that are looking after them? And then finally, is there a risk to people in the laboratories who are handling specimens? There have been outbreaks of certain infections because the specimens weren't correctly labeled or the history wasn't fully given. And that may well lead you to isolate the patient or use certain PPE to help protect. And that's clearly very relevant at the moment with regards to COVID-19. So some of you will see this table and groan in disappointment. Some of you may be like, okay, I think I can do this. But knowing about gram staining is really, really important. Again, not just for lists of organisms, but there's a practical purpose. So as I say, when you're working on the ward, you may well get a call from a microbiologist or an infection specialist saying, you know, that sample you sent us, whether it's growing, it's growing a gram-positive coccus or a gram-negative rod. And you have to know why that will be relevant to your patient. So for instance, if you get an organism growing which really doesn't fit with the presentation, could that be a contaminant? Or actually, if you've found an organism which you hadn't considered as a source of infection, do you need to go back and re-examine that patient and do some other tests, whether they're blood tests or radiological tests? So let's go through some of these categories in order. So gram-positive cocci, probably one of the more common infections and organisms you'll see in terms of groups. So Staph aureus, again, we've already mentioned this in terms of a common cause of skin and soft tissue infection, often part of our microbiome that usually sits fairly happily on our skin. So the Staphylococcus aureus clusters of organisms of bacteria, cocci round, gram-positive, so they'll look that sort of deep purple on the gram stain. Now, if you were told that your patient is growing a gram-positive coccus, which could be Staphylococcus aureus, you need to think, okay, I need to go back to my patient, think about, is there a sort of skin source of infection there? And not only that, has this actually now spread to other parts of the body? So you remember I mentioned that Staph aureus it likes to stick to certain parts of the body and form biofilms around particularly prosthetic material. So could this patient have endocarditis? Is there any sign or evidence of bone and joint infection if there's been hematogenous spread? So have a good feel of the back and the spine, have a good look at and a good examination of all the joints. That will be really, really important. Now, coagulase negative staph are really important to know about as well. Sometimes you'll get a call from the microbiologist and they're like, well, we're not sure, but this Staphylococcus may well be coagulase negative. Why is that relevant to you clinically? Well, again, coagulase negative staph also sit in the skin as your normal commensals, just like Staph aureus. If you find that there's a result back which is coagulase negative staph in a blood culture, the likelihood is that it's a contaminant. So someone's not used proper technique when they're taking their blood culture, and that organism has managed to get into the blood culture either from their own fingers or potentially from the patient's skin. So in general, if you find coagulase negative staph in a sample, it's probably not the cause of the patient's illness. However, if you repeatedly culture this organism from otherwise sterile sites, so let's say during an operation, a bone and joint infection, you find coagulase negative staph has grown 2 or 3 times from what should be a sterile environment, then that is most likely relevant and should be treated seriously. Then you come to the streptococci, and this can get a bit confusing in terms of how they're differentiated, but they shouldn't. So you've got your two main groups of streptococci, your alpha hemolytic and beta hemolytic. Now remember, these are microbiological terms. So when you culture these organisms on an agar plate, on the red agar plate, blood agar, you're looking at the zone of hemolysis around the colony that's growing. So alpha hemolytic, a smaller zone, that usually denotes that this is either strep pneumoniae, particularly if they're in longer chains, or the Streptomyces oralis group, which you may remember as being the strep viridans group. The strep viridans group on a single sample may not be relevant, but if you grow it multiple times on multiple blood cultures, then that may well point to the patient having endocarditis, and you should go back and examine that person's heart in detail. Consider doing a transthoracic or a TOE, a transthoracic echo or a TOE. Strep pneumoniae, again, if someone says, look, this is alpha hemolytic strep on this, we've done some other tests, it looks like it may well be strep pneumoniae. Does that fit with the clinical presentation? Go back, have a listen to their lungs. What else does strep pneumoniae cause apart from pneumonia? Bacterial meningitis. Is there evidence of that when you go back? Have you missed potential meningitis in a confused patient or an elderly patient with dementia? And then you have your other group, which is the beta hemolytic strep group. Now, these are then subdivided into your Landsfield grouping, which are basically the antigens on those streptococci. And the Landsfield grouping goes from A to E, although I'm sure this will probably change as microbiologists are always finding new terminologies. And you may well recognize that one of the Landsfield group, which is group A, which is also called strep pyogenes, or group A strep. Now, these infections tend to cause, again, skin and soft tissue infections. Group A strep is one important one to know because not only does it cause cellulitis, but it's the most common cause of bacterial pharyngitis, so throat infection, and it is associated with other systemic problems such as glomerulonephritis, scarlet fever, and sometimes endocarditis. So it's really worth knowing. And it's a common cause of necrotizing fasciitis because it's toxin producing. So if you find invasive group A strep, that is one issue in addition is that it's easily spread from patient to patient. So that patient often needs to be isolated until they've been treated. And you should look for complications of that. A smaller group there in sort of brackets is Enterococcus species. Now this is gram-positive cocci which live in our bowel, hence the name Enterococcus. It can be causative when it comes to GI-related pathology, sometimes UTIs, because that's where most of our UTIs come from our bowel organisms. It's less virulent than the ones mentioned above, especially Staph aureus and some of the other strep, but it shouldn't be forgotten as a potential cause for GI-related infections. So then we come to gram-positive bacilli. Now, this is definitely a smaller group of infections, and there's not many of clinical relevance, but listed here as a few that you should remember. So listeria is a cause of meningitis. So it's a particular problem in the very young and the very old and the immunosuppressed. So if you've got someone who's older than 50 or older than 60, they've got meningitis, you should think about listeria. And this is passed on through unpasteurized foods, particularly soft cheeses. If caught in pregnancy, unfortunately, it can cause problems for the fetus and stillbirth or miscarriages. The Bacillus species, you may recognize an infection called anthrax caused by Bacillus anthracis. Quite a nasty infection if caught from animals. It can cause nasty skin infections and ulcers, but also quite horrible disseminated disease, multi-organ failure, and severe pneumonia. And another species of Bacillus cereus, is a cause of gastroenteritis. The other important one comes from the Clostridium species. So these are your anaerobic. Everyone that I've mentioned so far generally is aerobic, but these anaerobic bacteria are really important. Clostridium perfringens causes necrotizing fasciitis, so it may well be the cause of a deep wound infection in neck fasc. But there's obviously C. diff, which is now Clostridioides difficile. And we know that this is a spore-forming bacteria, a real problem when it comes to nosocomial infections within hospitals, easy to spread because those spores are very hardy and hard to get rid of. So we should always think about risk factors for C. difficile. So that's older age, recent antibiotic use, recent hospital admission, and in someone who comes in with quite severe watery diarrhea. And in the elderly and immunosuppressed, it can be life-threatening and cause toxic megacolon and bowel perforation. And then you've got your other group, which is Corynebacterium. Generally, if you find that in blood culture, for instance, or even skin swabs, they're not so relevant because they're common skin commensals, what we call our diphtheroids. But again, unless you recurrently grow them from what should be sterile samples, such as perioperative samples, then you can normally ignore these. Apart from the one which is C. diphtheriae, which is the cause of diphtheria, a throat infection which has cardiac complications, often spreads in such as situations such as refugee settings, areas where people are living close together. Gram-negative rods or gram-negative bacilli, this is a much larger group. Again, you'll be called about this group very frequently, particularly the Enterobacteriaceae. So these are your predominant gut pathogens. So mostly in the gut, you'll get Enterobacteriaceae. You'll have a large proportion of anaerobic bacteria. You'll have some Enterococci and also Candida species as well. But Enterobacteriaceae sit there. If I was to take a sample of anyone's poo, you'll grow a whole host of these Enterobacteriaceae, and that's fairly normal. They sit there, as standard. However, if those pathogens get where they're not supposed to be, that's when you get disease. So these include bugs such as E. coli, of which there are many types, serotypes, Klebsiella species, Proteus, Salmonella, Shigella. So these are your Enterobacteriaceae. If they get into your urinary tract, they're the commonest cause of UTI. If they get into your biliary tree, such as in ascending cholangitis, they will cause pain, deranged LFTs, right upper quadrant pain in particular. If they get into your spleen, they may cause splenic abscess, and similarly into your liver, usually as a result of ascending cholangitis. If you were to perforate your bowel and get a spillage of the bowel contents into your peritoneum, and the samples were washed out by a surgeon, a large proportion of that will be your Enterobacteriaceae. So this result is really quite key. If you were called by a microbiologist saying this blood culture is growing E. coli, then you need to go back to your patient and think, okay, well, where is the source of the infection? Is there anything from the bowel? Have I missed a UTI? Let me go and feel this person's abdomen again. Is there right upper quadrant pain? Do we need to consider doing an ultrasound of their biliary tree? Could there be an abdominal source? Does this person need a CT? Do their symptoms fit with the bacteria that we found? And are they getting the right antibiotics as well to fit with that? Pseudomonas, some of you will have heard of. So this is really an opportunistic pathogen, quite commonly found in people who have had courses and courses of antibiotics, so potentially in diabetic foot infections or patients who are on ITU who unfortunately often need lots of antibiotics. Pseudomonas hangs around. When the other bacteria are wiped out, it starts to grow and often colonizes different parts of the body. It's quite difficult to get rid of and can be quite virulent, and only certain types of antibiotics actually work on Pseudomonas compared to, let's say, your Enterobacteriaceae. And then there are other non-enterobacteriaceal gram-negative rods, such as Haemophilus influenzae, which you'll all recognize as a cause of pneumonia, less so now because we get immunized against this in childhood. And then finally, gram-negative cocci. Thankfully, there's not many of clinical significance. The two main groups are Neisseria meningitidis or Meningococcus, and the other is Neisseria gonorrhoeae gonococcus. So hopefully you'll recognize Meningococcus as a fairly common cause of bacterial meningitis, probably one of the most dangerous causes of bacterial meningitis, can also cause sepsis or septicemia. And then gonococcus, which I guess less dangerous, it's an STI. It can cause urethritis, cervicitis, but it can also cause unrecognized or undiagnosed pelvic inflammatory disease. The problem with Neisseria gonorrhoeae is that it's very highly resistant now, and actually we've had cases where it's been so extremely drug resistant that there's been some cases where no antibiotics would, at least in terms of laboratory tests, work against it. So hopefully this has given you a good rough breakdown of the common organisms that you're likely to see. I want you to grasp some of these and start to recognize them as something you'll see more frequently as you go on. And if I was to ask you about potential differential diagnoses, you should refer to this page as your potential cause for causative organisms. So let's go through the common infections. You're going to see, well, we've gone through lots of them already. Skin and soft tissue, that's a very nasty cellulitis, and it's probably a group A strep infection. So this infection may cause cellulitis, may cause necrotizing fasciitis. So we've said already this will either be Staph aureus or some of the Lancefield grouped streptococci, such as group A strep or group C or group D strep. Musculoskeletal, very similar to skin and soft tissue. So the same organisms manage to get into your joints, whether it's by direct contiguous spread or whether it's hematogenous spread from an infection elsewhere, let's say from the skin. So infection in joints will be either, again, Staph aureus or some of the streptococci. It's really important to know, like this knee is very swollen in this picture, is this a native joint or a prosthetic joint? Prosthetic joints are much more difficult to manage, and often, because of the biofilm formation of organisms like Staph aureus, antibiotics alone may not clear it, definitely not short courses. A person like this may end up on 6 months plus of antibiotics, or even need the metal taken out to fully clear it. Don't forget spondylodiscitis. It often does get forgotten. So this is infection in the vertebra or in the discs of the spine. So particularly if you have someone, let's say, with Staph aureus, ask them about back pain, new back pain. You often won't be able to feel it or palpate it, so you may well need to go for imaging, such as an MRI, to diagnose. An osteomyelitis, either via contiguous spread from a septic joint, perhaps, a chronic infection that can lead to, often leads to osteomyelitis, such as in diabetic feet. So if you've got somebody with a chronic diabetic foot ulcer, which is really not healing, or they've been on antibiotics for months but not getting better, is there actually underlying osteomyelitis? And you may need to do some radiological tests to find out. And these will again need weeks, potentially months of antibiotics to treat fully. Cardiorespiratory. Very frequently in primary care, you'll see upper respiratory tract infections. Most of these we can ignore. They don't need antibiotic treatment, apart from the occasional bacterial pharyngitis caused by group A strep. But lower respiratory tract infections often do. So these are your typical organisms that cause community-acquired pneumonia. So strep pneumoniae, Haemophilus, Mycoplasma. You may get exacerbations of COPD in your respiratory department. You'll see a lot of this. It's a common condition now. And don't forget what we call the atypical pneumonias. They're only atypical because they present not in that bronchopneumonia lobar picture, like you can see that on that chest section, a nice patch of consolidation. There may be more widespread or bilateral changes, such as in Mycoplasma or in Legionella. We mustn't forget TB, and there's a case of TB in your workbook, which you should be able to go through and ask questions about and at least recognize the management for. And the most common cardiac infection that you'll come across is endocarditis, and we've touched upon that already. Gastrointestinal, again, most causes of gastroenteritis won't need any antibiotic treatment. So many will be viral, obviously, things like norovirus, which is symptomatic management alone, although it's very infectious. Your sort of straightforward food poisoning, such as from Campylobacter, common cause of food poisoning from undercooked meats, barbecues in the summer in particular, don't necessarily need treatment. They will get better on their own. However, certain types of gastrointestinal infection will, so Salmonella typhi, which can cause bacteremia and become a systemic infection. C. diff, which will definitely need antibiotic treatment to prevent disease and to prevent spread. If you were to have visceral perforation peritonitis, remember the bugs, we've talked about them, you're much more likely to find isolated a gram-negative rod or an anaerobic infection, and that's such as E. coli or some of the other some anaerobes as well. And it's important that you think about those infections when you're planning your treatment and the source control. Hepatobiliary infections, we've mentioned this. Again, usually they're caused by Enterobacteriaceae or anaerobes, whether it's in the biliary tree or liver. And then I mentioned there viral hepatitis as possible infections that you may see in secondary care, although these are usually managed in the chronic, in the sort of clinic setting. A and E and potentially B are some that you might come across. I've stuck in there also H. pylori. It won't present with fever. They won't present particularly unwell from an infection or sepsis point of view, but we know that a lot of duodenal ulcers in particular are caused by H. pylori, and antibiotics would be needed to clear. Genitourinary, not going to focus on PID here, but just remember that your common infections, particularly bladder infections, cystitis, you may well see them very frequently. You'll need to know how to recognize and treat. You now know that most of these are caused by your Enterobacteriaceae, such as E. coli. Some of them may be caused by Enterococcus. And remember, you must differentiate cystitis from pyelonephritis, which is a much more serious infection, often involves bacteremia, and they may well be very sick and septic. But again, the organisms are likely to be the same. CNS disease. So look at that picture at the bottom. It's a leg. There's a lot of sort of horrible sort of necrotic purple looking rash. When you press on it, it doesn't blanch. That is the rash of meningococcal septicemia. It's in a medical emergency. This person needs antibiotics straight away. And you need to give them the most appropriate antibiotics. Remember, there is a difference between meningitis and encephalitis. Meningitis is obviously inflammation of the meninges, the outer layer of the brain and central nervous system. So the symptoms you'll get from that are neck stiffness, photophobia, fever, and headache. Whereas encephalitis, you may get meningitis, but you may not. So you may just get the patient presenting with confusion, decreased GCS, or focal neurology, depending on which part of the brain tissue itself is swollen. And then sometimes both meningitis and encephalitis can lead to a brain abscess because of the same organisms. So Neisseria meningitidis, strep pneumoniae, possibly listeria, possibly even TB if this is more of a chronic picture. And they may need some surgical intervention. I haven't touched upon this yet, but we must mention immunodeficiency. So you need to recognize common causes, but also what kind of infections these patients are likely to get. So whether this is in somebody with chronic HIV with a very low CD4 count, or whether they're on medications and drugs that can lower their immune system. Common infections will still occur, but they may occur in a much more severe way. So whether it's a pneumonia or a gastrointestinal infection. But the other thing that often happens in immunodeficiency is that your latent infections, these human herpes viruses such as herpes zoster, varicella zoster, they may reactivate much more severely. So this is a typical dermatomal rash of shingles, varicella zoster virus. Shingles doesn't necessarily occur only in those who are immunocompromised. Many of you may have had shingles outbreaks before. We know it happens in the elderly as immune wanes slightly. And usually it will go away by itself or with a course of acyclovir. However, if reactivation occurs in immunosuppression, it may cross dermatomes, it may be really widespread and look like the primary infection of chickenpox. And these patients often need to be admitted and given intravenous acyclovir to prevent really severe disease. And we mustn't forget the congenital immunodeficiencies as well, which I won't really talk about here. And then there's the not pleasant issue of iatrogenic infections which we unfortunately do to our patients, usually because we've not really thought about them enough or taken enough care. So post-op wound infections, unfortunately, will happen even with the best will in the world and the best intraoperative aseptic technique. So any surgical wound can get infected, and one of the surgeon's jobs will be to look at the wounds after the surgery and see, does this obviously look infected? Is there pus coming out of there? Is the wound line becoming red? Is the wound dehissing? That will be clearly a sign of concern. Sometimes it can be managed by infection. Sometimes that wound needs to be reopened and washed out because antibiotics alone won't treat them. If you look at this arm here, you can see there's a cannula in there, a line of some sort. There's redness around there in particular. That's worrying. So that is a line infection. What do you think is the best treatment? Yep, take the line out. You've got a source of infection there. Doesn't really need to be there anymore. Take it out. They may well need some antibiotics as well. What's the likely organism? Again, it's going to be your skin and soft tissue infection, so Staph aureus and some of the streptococci. Easy. And finally, you've got any other prosthetic material that can cause infection. So urinary catheters that have been in too long, pacing wires, again, they can all become niduses of infection. So think about those materials when you see somebody with a pyrexia of unknown origin, somebody who's, let's say, grown a Staph aureus, and you're thinking about hematogenous spread. And then the other important issue is to think about infection prevention and drug resistance. Now, unfortunately, this is becoming a really big global problem, probably one of the biggest problems affecting us as the human race, I would say. The amount of drug resistance in our standard infections is definitely becoming more problematic. One of the commonest ones that you'll probably have heard of by now is MRSA, methicillin-resistant Staphylococcus aureus. So methicillin is an antibiotic. It's not one that we use to treat people with, but it is one that's used in susceptibility testing in the lab. So if Staph aureus is found to be methicillin resistant, it is essentially resistant to the most common antibiotic that we use against it, which is flucloxacillin, a penicillin, and I'll go into that in more detail in the next talk. It's often based around toxin production, and patients are usually colonized with this beforehand, and it's easily spread between household members. So you may find on a surgical placement, everyone preoperatively has a MRSA swab done, and if they are MRSA positive, you can decolonize, give them topical treatment to get rid of it, but also that patient may well need isolating. And if you find MRSA in a blood culture or another sample, then you'll have to change your antibiotic regime. ESBL producers, I'm hoping you've heard of this, you may not have. So this is extended spectrum beta-lactamase producing bacteria. So what's beta-lactamase? So if you remember, if you think about your commonest antibiotic, penicillins, they are beta-lactam antibiotics. The other beta-lactam antibiotics are cephalosporins and carbapenems most commonly. So these all have the beta-lactam ring. And traditionally and historically, they've been really, really helpful in fighting off most infections and most bacteria. However, bacteria are clever. They've developed a resistance to many of the beta-lactam antibiotics by producing an enzyme called beta-lactamase, which then breaks down the beta-lactam ring. So, for instance, E. coli at one point was sensitive to amoxicillin. It no longer is throughout the world. However, if you add on clavulanic acid to amoxicillin, produces co-amoxiclav, that still works against many E. coli species. However, if you've got a bacteria which produces extended spectrum beta-lactamase, usually these are your Enterobacteriaceae, such as E. coli and Klebsiella, most of our normal antibiotics no longer work against these. And the only antibiotics that will work are carbapenems, such as meropenem. So we're finding many more of these as standard as part of our normal microbiota in the community. So unfortunately, we're seeing many people coming in with UTIs, for instance, which have ESBL, even though they're not particularly unwell with it, but we have to start to use intravenous antibiotics much more frequently than simply being able to use a 3-day course, a three-day course of nitrofurantoin or trimethoprim. And then one step worse than that is carbapenem resistance. So this is now becoming, again, more of a problem globally. There are a number of resistance types which can induce resistance to the carbapenems, which you remember is really our big guns against infection. So a lot of this started to come from the developing world, such as Southeast Asia, particularly in India originally, where unfortunately there isn't the same antimicrobial stewardship that we have here. Antibiotics are often easily and readily available. They're used when they're not supposed to be used. Broad spectrum antibiotics are used when they're not supposed to be used, when a narrow spectrum will do. And all of this drives resistance to bacteria, particularly the broad spectrum antibiotics. So now we are screening many people for CRO or carbapenem resistance, particularly patients who have transferred from another hospital, whether it's here in the UK or abroad, and that's a key thing. We will be screening more with rectal swabs to see if CRO organisms are a standard part of our microbiota now. And so if that person becomes unwell, they may well need a much more broad spectrum, potentially toxic antibiotic. And if you ever find that this patient, or you know this patient has any of these particular types of organism, MRSA, ESBL, they should be isolated early to prevent that being spread to other people, to other patients, and that then becoming part of their normal microbiota and using the appropriate PPE. And then that final sums up the antimicrobial stewardship part of this, which essentially is safe prescribing. So the key aspects of this are don't give antibiotics unless you need to. So this sounds pretty common, like common sense, but you'd be surprised at how often it happens. So the little old lady who's fallen over, she's confused, the urine dip's positive, oh, it must be a UTI, let's give antibiotics. Often elderly patients have asymptomatic bacteriuria. It's not the cause of their disease. What are the other aspects of the history or examination that point to a UTI? Does this person actually have dysuria or not? And if they don't give antibiotics for a UTI. If you do need to give them, give as narrow spectrum as possible. At least then they won't become resistant to the broad spectrum options that we have available. Give intravenous for a shorter time as possible. That also reduces the chance of resistance. And use hospital guidelines. That's what they're for. So many of them were produced to prevent the inappropriate use of broad spectrum antibiotics or antibiotics when they're not needed. So this is a key thing. We'll be talking about this and you need to know about it. The final part of this aspect of the talk is sepsis. Really key. A few years ago, UHL was criticized for its management and recognition of sepsis. Since then, we've put in a lot of effort to improving our recognition, including electronic observation, which the EOBS, which then flags up when someone may have sepsis. So in 2016, the NICE guidance for diagnosing sepsis changed. Some of you might remember the term SIRS, which was used, but this was found to be not particularly helpful. When thinking about sepsis, sepsis itself is life-threatening organ dysfunction caused by the host response to infection, the dysregulated host response. So sepsis isn't in and of itself because of the organism, it's the host's reaction to the organism. And then the worst part of sepsis is septic shock, which is a subset of it, which causes profound circulatory, cellular, and metabolic abnormalities. And the problem with this is that the mortality is much higher than sepsis alone. Sepsis mortality is 10%, but septic shock is over 40%. And there's a reference there to look into this in more detail. So how do we recognize sepsis? Well, on any ward that you go, you will find the adult sepsis screening tool. And you'll be expected to know this. So anyone could have sepsis, and that's a difficult thing to get your head around sometimes. We may well overdiagnose sepsis, but the trust feels that it's better to overdiagnose than underdiagnose. So when you look at your EWS score, your early warning score, is the score 3 or above? Does the patient look sick? Now that might sound very vague, but as you get more clinical experience, you will recognize the sick-looking patient, and it will be pretty obvious to you from the end of the bed. If neither of those things are true, then the risk of sepsis is low. You can generally stand down. However, either of those is true, then this person could have sepsis. And then you have to think, is there an infection? And again, you'll go through all of those things that we've just talked about. Look at the history, go through the examination, look at the blood test results, inflammatory markers, all of those things, and think, is there evidence for infection here and where is it coming from? If there may well be a clear source or there may not. Either way, you then go to the next part, which is there a red flag evidence of sepsis, sign or symptom or finding? And if there is, then you need to start the sepsis 6 bundle straight away. So this includes respiratory rate being high, a new need for oxygen. Remember, giving high amounts of oxygen to patients with COPD is not necessarily safe. So do they suddenly need more oxygen to keep their SATs above 91% or 88% in COPD? Has their systolic BP fallen? Are they tachycardic? And have they not produced urine for many hours? They're all bad signs of them being intravascularly deplete of peripheral vasodilation. Other things you might just see from looking at the patient: has their responsiveness gone down? Is their GCS lower? Are they only now responding to voice or pain when earlier they were fully alert? When you look at them, do they look unwell? From the skin, it's sometimes just looking for this sort of mottled appearance, which can appear in sepsis because all of the blood flow is now gone to the vital organs and they become peripherally shut down. That's a bad sign of intravascular depletion. Can be caused by other things other than sepsis, but it may well be sepsis. And if they've got any one of those features, start the sepsis 6 bundle definitely within an hour, but as soon as possible. So you might remember this in different ways. You may remember this as measure 3, give 3. I've used buffalo here. So 6 things. So take blood cultures, measure a lactate, and measure urine output, and give a fluid challenge, usually with a 500 ml bolus of normal saline or Hartmann's. Give a broad spectrum antibiotics as per your trust policy. In UHL, it's meropenem. And also give oxygen if it's needed, not always needed in every case. Now, you don't stop there. You must go back and reassess the patient, go through the A to E again, make sure that the measures you put in place have worked. If so, great, continue them, continue with maintenance. And then when it comes to the source of infection, think about that. Where is the source control going to be? Think about where that infection has started. Will antibiotics alone manage it if, let's say, it's pneumonia? Is there the need for a surgeon to be involved if there's an abscess somewhere? Because the likelihood is that the sepsis is not going to get better on its own without good source control. So in summary, for this section, we've focused on the history and examination as being key elements of what you need to be able to recognize infection in the patient, as well as starting to think about investigations such as microbiological samples, blood tests that will be helpful, and radiology. I've hopefully got you starting to think about the source of infection, the route of infection, how it gets into where it's not supposed to be, and then the consequence of infection, whether it's an acute infection such as sepsis, or whether it becomes a chronic infection or potentially an operative problem. We've talked about sepsis now in great detail. You need to know about that. And again, this is hopefully a starter to you thinking about the holistic management of infection. Now, in the second section, we'll talk specifically about antibiotics. What are the common antibiotics that you'll see being used quite frequently? Which scenarios should you use them? And I'll also go through a 10-point approach to managing the infected patient, and we'll go back to that case that we went to at the beginning. See you then.